disorders of fluid and electrolytes, maintenance intravenous fluid in acutely ill patients. Definition. Intravenous fluid may be required as a bolus infusion for resuscitation or as a continuous infusion when sufficient fluid cannot be ingested orally. Intravenous fluid can be classified according to the concentration of sodium plus potassium in the fluid, as being either isotonic, approximately equal to the plasma sodium concentration, or hypotonic, less than the plasma sodium concentration. Application in medicine. The goal of maintenance intravenous fluid is to preserve the extracellular volume while maintaining a normal electrolyte balance. An appropriate maintenance fluid provides an adequate quantity of both water and electrolytes to ensure good tissue perfusion without causing complications related to fluid overload or volume depletion. It also prevents the development of hyponatremia, hypernatremia, and another electrolyte imbalance. Pros and cons. In pros, the dextrose content of intravenous fluid has no effect on the tonicity, since the dextrose is rapidly metabolized when it enters to the bloodstream and should not produce hyperglycemia. A study involving almost 700 children showed that the odds ratio for prevention of hyponatremia with an isotonic fluid was similar among surgical patients and non-surgical patients, and among patients who were in intensive care and those who were in non-intensive care. And in cons, the administered hypotonic maintenance intravenous fluid in both children and adults have been associated with a high incidence of hospital-acquired hyponatremia and more than 100 reports of iatrogenic deaths or permanent neurological impairment related to hyponatremic encephalopathy, since acutely ill patients may have disease state associated with an excess of arginine vasopressin. Isotonic fluids may result in hyponatremia in patients with CNS injury in whom cerebral cell wasting develops, or in patients with the syndrome of inappropriate antidiuresis in whom the urine osmolarity is greater than 500 MOSM per kilogram. Failure to recognize and treat hyponatremic encephalopathy with hypertonic saline results in a poor neurological prognosis, and disease or medications that disrupt the medullary interstitium or interfere with the action of ABP will result in a renal concentrating defect and can lead to hypernatremia in patients who restrict access to free water.
This is a short presentation explaining how the NICE guidance on intravenous fluid therapy will be diagnosed children. We're going to first look at complications of inappropriate or unmonitored IV fluid. We're going to look how the guidelines try and reduce these complications, and we're going to explore how we plan to implement the guidelines. When poorly in hospital, children's electrolyte balance and fluid balance can be affected, and problems with abnormal electrolytes or problems with fluid overload and hypovolemia can be made worse by inappropriate or unmonitored IV fluids. Electrolytes of particular importance are potassium and sodium. There have been recent patient safety alerts because rapid changes in sodium have resulted in neurological injury and death in children, and inappropriate intravenous fluid therapy has contributed to these adverse events. The NICE guidelines state that for maintenance fluid, initially isotonic fluids, which in electrolyte composition most closely resemble normal human blood, should be used. Potassium should also be added routinely unless there's a contraindication, like renal failure. user needs should be monitored daily to guide fluid prescribing. However, for lots of reasons, children might need alternative fluid prescriptions. If this is the case, decisions will be led by the responsible medical team. Unless deemed clinically inappropriate, weight should be monitored daily and any changes noted. Fluid balance charts should be updated with running totals and also daily totals and overall fluid balance. As well as raising awareness through this video, we will also be adapting fluid charts to try and help keep within these guidelines. The new IV fluid prescription charts now contain an area where maintenance doses can be totaled, where alternative fluid plans can be justified if necessary, as well as the normal space to write a prescription. If rates of fluid administration or type of fluid is not in keeping with the guideline, for example, fluids with different saline or potassium concentrations are used, the justification can be now clearly documented on these charts. In addition, fluid balance charts now have an extra section where weight can be recorded and compared to previous days to look for any differences or fluctuations in weight, and prompts to calculate daily fluid balance have been made clearer. In summary, 0.9% saline fluids should be first line, and fluid prescription charts should explain why this isn't the case in certain situations. Please ensure that weights, fluid balance totals are kept up to date and checked regularly. Applying the guidelines by using these interventions should help ensure the safety of children on intravenous fluid therapy at this hospital. Thanks very much for listening.
Issue applied in Ecuador. In Ecuador, the administration of parenteral fluids and electrolytes is the essential support therapy in acutely ill children if the oral route does not allow the administration of the required amount of or composition of fluids. For example, in gastrointestinal, respiratory, neurological disease, or in a transoperative period. Maintenance fluid are given to preserve the extracellular space and to replace normal water losses, including transpiration, loss of water vapor during respiration, urine, and feces, as well as to cover the water requirements for metabolic and energetic reaction. The administration of maintenance fluids should be appropriate in quantity and composition in order to preserve the child's extravascular space and at the same time to avoid volume depletion or overhydration, as well as electrolyte disturbance, in particular hyponatremia or hypernatremia. And finally, the human body has no remarkable ability to maintain a normal composition of body water and plasma osmolarity, despite wide variations in fluid and electrolyte intake. Data from studies to determine whether balanced solutions are superior to saline solutions for maintenance fluids and to determine the most appropriate potassium concentration in fluids are lacking. A solid evidence base from which consensus guidelines for fluid therapy could be built in is also needed to better standardize fluid management.
Normal saline is a commonly used isotonic intravenous crystalloid fluid. Although it was created to approximate the same osmolarity as human plasma, normal saline contains higher sodium and chloride concentrations than plasma, and its infusion can lead to hyperchloremic metabolic acidosis and kidney injury. Balanced crystalloid solutions, such as lactated ringers and plasma light A, have more physiologic electrolyte concentrations, and thus may have less negative impact on acutely ill patients. In the single-center pragmatic unblinded SALT-ED trial, investigators tested whether the composition of crystalloids affected outcomes in non-critically ill patients. Over 16 months, the trial enrolled 13,347 adults who received 500 milliliters or more of isotonic crystalloids in the emergency department and were subsequently hospitalized, but not in an ICU. In alternate months, participants were assigned to receive either balanced crystalloids or saline. The median crystalloid volume received was 1,079 milliliters, and 88.3% of patients received only the assigned fluid. The primary outcome of hospital-free days, defined as days alive after discharge before day 28, was the same in the balanced crystalloids group and the saline group, 25 days versus 25 days. Patients in the balanced crystalloids group had a lower incidence of the secondary outcome of major adverse kidney events within 30 days, which was a composite of death, renal replacement therapy, and persistent renal dysfunction, 4.7% versus 5.6%. A concurrent study performed among critically ill patients also showed a reduction in major adverse kidney events within 30 days, 14.3% with balanced crystalloids versus 15.4% with saline. The authors conclude that among non-critically ill adults, balanced crystalloids and saline resulted in no difference in hospital-free days. Full trial results are available at nejm.org.